And don't worry, I'm not going to nap during the session, although potentially, but not likely. And I just want to disclose that I don't have any financial or commercial interests. I haven't received any other in-kind support. And my only conflict of interest is that I'm just a shameless fan of Trek, which I don't know if that's a bad thing. So these are the objectives that we'll try and address today. We'll try and keep it mostly case-based. I've got a little bit of didactic stuff. And we'll briefly review what asthma is and how it's diagnosed, again, keeping that short. Go into asthma management in the emergency department, and sometimes that does spill out, beyond the emergency department, because that relates as well. The treatment in the community helps prevent people from coming to the ED. Talk about some new and emerging evidence and offer some practical tips that I've learned over time and just things that might help. Usually when I do an in-person session, I make lots of questions and open discussion that we can have. I know it's a little harder to do it virtually, so yeah, please put your questions in like Megan suggested. I will still ask questions in the text, but rather than waiting for a response, we'll just take a second or two and just think about your own response, and then we'll move on. So let's get started. And again, feel free to ask questions at any point. So what is asthma? Keeping it really short, it's much more complicated than is on this slide. There's all kinds of variants, but basically it's a chronic, episodic, so on and off inflammatory airway disease. Leads to airway hyperresponsiveness, so the airways get quite sensitive. They become edematous, muscle spasm, and mucus production. So all of that restricts airflow. And so you end up air trapping. And the really big point about asthma that I think a lot of us don't realize, asthma it's not an inspiratory problem. You don't have a problem breathing in, you have a problem breathing out. You are trapping air. As those airways, and I'll show on the next slide, become edematous, air gets trapped kind of downstream. I do want to highlight a really important thing, though. We're learning more and more about undertreatment of asthma. I did my med school in the early 2000s, and then we were taught, if you have poorly treated asthma for quite a long time, by the time you're a young adult or so, you can potentially get permanent airway remodeling, where the cellular layers and membranes in the airways enlarge and tighten up and narrow the airway. There's recent evidence within the last couple of years that kids as little as 2.5 years old with poorly controlled airway management can actually have this remodeling. So that's really caused us to step up our concern and aggression with treating asthma. So here's just a little schematic. So you can see on the left, there's the nice patent airway, no edema, no secretions. Good airflow through there. And then on the right, that edema, and that you can even see there that acute thickening of the membranes. And all that does is, again, restricts that airflow, causes the wheeze as that air is trying to squeeze through those little airways. And you trap air. So that airway will actually collapse before all the air is drained out of the alveoli. And you take your next breath, and again, you fill that alveoli more, and it doesn't drain completely. So over time, you hyperinflate. These kids, when you x-ray them, they have big inflated lungs when they're quite bad. And we know asthma is common. I don't imagine there's anybody on the talk who doesn't know someone with asthma. Nearly 1 million kids in Canada, 850,000 kids under 14 have been diagnosed with asthma. Lots of school absenteeism, hospitalization, healthcare costs, family disruption, and about 250 deaths a year in Canada. And this includes adults as well. But I do remember, and this was in the news, the child's been identified and everything. A child in central BC last year during the forest fires, which are back again, died of an asthma exacerbation, likely or in some part related to the smoke exposure. And it's also becoming more frequent. And we've got several ideas as to why. The hygiene hypothesis has been around for quite a while. We just think that with living in a too clean environment where we're sanitizing everything and not exposing ourselves to a lot of those common allergens when we're little. If we're not exposed to them when we're little, our immune system seems to get less tolerant as we get older. So that might be one of the issues. There's some really interesting stuff. Again, I said I'm from a small town, Manitoba. And I didn't look up these stats for this talk, so I don't remember the numbers, But allergies and asthma are significantly lower in rural kids. And apparently allergies are also more common in families who use their dishwasher more. So kind of ties in with the hygiene hypothesis. So environmental exposure, like more smoke exposure, just pollution in general. Obesity is also a risk factor. And that gets more complicated because sometimes there's other lung issues that kids with obesity can have. And exposure to lots of antibiotics and potentially even acetaminophen have been associated with more asthma. And I refer to these guys on the top here as the close relatives. So you've probably seen this where you have a kid who's got asthma or the sibling has it. They've also got allergies. They've got a chronic drippy nose and they've got eczema. So that whole tetrad is the sort of allergic asthma spectrum. I've mentioned bronchiolitis here. Bronchiolitis isn't part of that. It's a bit different. But I refer to it as the distant cousin who drops in every winter and just wrecks the place. I do have a talk on bronchiolitis. I'm going to touch on it a little bit today, but not that much, but just that it gets in there and confounds us, and we all just really hate bronchiolitis. So some of the precipitants, and I'm trying to be clear here, precipitants and causes, there can sometimes be some overlap, but really what I'm referring to now is when you already have asthma, what can precipitate your asthma exacerbation. I'm not going into all the causes of asthma. See, these are some of the common ones, and there's a few more written on the bottom there, but there's a laundry list of things that can precipitate your asthma exacerbation. But which one do you think is the most common precipitant of asthma in kids? Again, I'll just quickly move on, but that's the one that gets us a lot. So viral infections. Specifically, there's one virus that's more prone to causing asthma exacerbations, but multiples can do it. The one that we see most commonly is rhinovirus. It's a known precipitant of asthma, and it's one of the indicators when we get to some slides up ahead here about when we can treat for asthma in a younger kid. But yeah, viral infections, but all these other things can do it too, and often it's combinations of these, for instance, if there's a viral outbreak going on and smoke exposure, like we're having, not today, but the last few days. So it can be multifactorial. So how do we diagnose it? In an ideal world where, you have all the resources and everything's accessible, we would do pulmonary function studies. This is not something we routinely do. So not every kid needs this. And you can see that kid there. I don't know how old that kid is, but it looks like he's about maybe 8 years old or something like that. And that's about the age where you have to be able to do these pulmonary function studies. So A, we don't necessarily need it on every kid, and B, you got to be a little bit older to do it. And again, access would be an issue. On the bottom there, not going to look at this at all, but you can see the graph that you get, and the blue and the red is pre-salbutamol, and red is post. And again, we're not going to look into it, but that's how we measure lung airflow. So, but really, again, uncomplicated asthma should be a clinical diagnosis, and I'll talk about the clinical diagnosis in a second. What about this kid? So how do we diagnose asthma in this kid? I know it's a disgusting picture, but I had to do it. She's 14 months old. There's no chance that she's going to be able to do PFTs for years. So how do we diagnose asthma in the young? Oops. So the Canadian Thoracic Society, they came out with a statement in 2021, and they had one about 6 years earlier with the Canadian Pediatric Society about this. And one of the problems we had noticed, or they had noticed, is ongoing delay in the diagnosis of asthma. So kids were being called happy wheezers. I forget all the different variations, but all these different terms. And they were like, okay, we need to clarify this and sort out who has asthma and how to define it. So this is for little kids who preschool age who can't cooperate with pulmonary function studies, but also if you don't have access, this is for any age population. So number one is a history compatible with asthma. So if the parent tells you, yeah, on and off, Every time she gets a cold, she wheezes a lot. Ongoing nocturnal cough, ongoing wheeze, difficulty breathing, the classic features, right? Wheezing, sputum production, and cough, as well as confirmation of a highlighted reversible airflow obstruction, right? So responsive to treatment. And the two methods of diagnosing that, one is if you witness it, so either in front of you where you're treating a kid with salbutamol, or if you're in a clinic, putting this kid on salbutamol and a corticosteroid and seeing that they improve. But seeing that also on repeated occasions. Perhaps one trial of salbutamol and an oral steroid and the kid looks better. Maybe that was just luck. So we usually say on recurrent episodes. Or if you're again in a clinic and you're busy, a convincing report from a parent who can reliably describe to you what the kid has and how they respond. So you don't have to witness it in front of you. Provide the treatment to the family, see them back in a little while and see if the kid has responded. One thing that's nice now is getting video, and I recommend this for just about everything. If the parents are treating this kid at home and you want them to give you some a little more objective stuff, tell them to obtain video before salbutamol and obtain video after. And you can actually look at that and see if it's an adequate response. So we don't use those terms like happy wheezer and all that stuff anymore. If you have one episode and you respond to salbutamol and steroids and so forth, we would call you suspect asthma or emerging asthma. And then if you have two episodes, so a month later, kid gets another cold or is exposed to smoke, gets symptomatic, and it's reversible with salbutamol, then it's asthma. So 2 episodes, it's asthma. Not because you've probably encountered that yourself, where we see this in Emerge all the time, where a kid has been for 2 years, has been in and has had several asthma exacerbations and say, no, he hasn't been tested yet, so we don't know if it's asthma. But if they've responded, it's asthma. Okay, enough of that. And again, subtypes and minute details, that's the kind of stuff that we're not going to cover today. So back to Annie. So she's 14 months old. She's our first case. Day 3 of a little bit of a fever, cough, rhinitis, noisy, labored breathing, wheezy, working a little bit hard, breathing fast, not feeling great. So if you have pediatrics in your practice, you have seen many kids with this. But she's been a healthy kid. She hasn't actually wheezed before. She's not on any medications or doesn't have any allergies. But her brother does have asthma and eczema, and we know that there's a significant family history or family inheritance pattern for asthma. She's a low-grade fever, respiratory rates 52, tachycardic. Now that might be that she's dehydrated, might be she's just upset, she's in pain, or that she's just working really hard. And she's hypoxic, right? 90%, not horrible, but not optimal. Hopefully she's not such a wiggler and an upset kid that we can actually get a SAT. She's congested, she's got decreased breath sounds bilaterally, wheezy and crackly. Asthma? I don't know. She's 14 months old. What else could it be? Again, trying to think of a couple of things, but we've talked about bronchiolitis already, for sure. Always on that list. And then asthma, of course, and pneumonia. We'll cover this a little bit later. So here's my only brief chat on bronchiolitis. So mostly now, 1 year of age, and I say now because I'll get to that in a second, but it's typically under 1 year of age. It decreases in frequency after 1, usually gone by about 2 or less even. Findings just like this kid has. So wheezy, congested, low-grade fever. Bronchiolitis sounds a lot like asthma. So one problem when you see these kids in your clinic or in the Emerge is that it's very fluctuant. So we will see they'll present to the triage desk and they're quite wheezy and quite tight and quite miserable. And then you see them an hour later and they're actually looking a little bit better. And then a couple hours later, they're worse again. So it fluctuates. That's kind of another feature that we see with bronchiolitis. But how do we sort this out? So I just finished saying that bronchiolitis kind of disappears at less than 2. And the old thinking, and I've had that within the last year, I've had learners tell me that they've been taught this, is, well, yeah, it's really if it's under 2 and they're wheezing, it's bronchiolitis, you don't give salbutamol, period. If they're over 2, it's asthma, it's not bronchiolitis, it's give them salbutamol. So that should be long dead and gone, but it's one of those zombie things that keeps coming back to life. I don't hear it nearly as much anymore, so hopefully I'm talking to the converted and we're done with this. But asthma does occur much younger, and I got some info on another slide. And kids get that mix too. There's no reason you can't have 2 illnesses. There's a big RSV outbreak and a kid who's got atopy in the family. So I call it brasma, right? Bronchiolitis combined with a bit of asthma. And this is my not very scientific graph, but I'm trying to illustrate the point here is that when you're really young, it's really predominantly bronchiolitis that presents like this. And then as you get older, even beyond about 6 months, is when we start to see asthma poking its head up. And then by the time you're somewhere, and again, this isn't a very scientific graph, it's me barely knowing how to do this, that by a year, a little after a year, the likelihood of asthma is greater than bronchiolitis. So sorting this out, I saw a question there, but I'll carry on. So here's when we might try salbutamol. And so salbutamol, I tend to use the generic term Ventolin, or if you're from the US, albuterol. So I just use salbutamol, the blue puffer. So here's when we could suggest it. I mentioned a while ago, rhinovirus is one of our known precipitants. So if you're over 6 months old and you know there's rhinovirus in the community, you might not know this kid has rhinovirus yet, unless you've done a rapid swab, but you know that it's prevalent in the community, it's worth a try. If the kid has atopy, so that's that tetrad again, there's eczema, family history of eczema, allergies, so forth, it's worth trying it. And if they're presenting in a non-bronchiolitis season, so the bronchiolitis patterns have messed up a little bit post-COVID, but usually bronchiolitis will hit for a month or 2, sometime between November and March. But if suddenly this kid looks in significant respiratory distress and it's July and you haven't seen bronchiolitis for weeks or months, worth a try. And the classic, and nothing is ever perfectly classic, but the classic characteristics of bronchiolitis is your wheeze starts a day or 2 or 3 into the illness. So if they're coming in on day 1 and they've only been wheezing for a few hours, that's again in favor of it being an asthma exacerbation. None of it's hard and fast, but it's worth a try. And as I said earlier on that slide from the Canadian Thoracic Society, if you really want to see a good sign of response, something definitive, when you go back into the room 20 minutes later and the parent says, well, I think it maybe helped, that to me, that's not helpful. That's optimism. Maybe the kid coughed out some secretions. Maybe it was that fluctuant pattern of bronchiolitis. So I want them to say, oh yes, definitely improved. Or we use the PRAM score. So and we'll look at that right now. So this is the PRAM. It's actually validated down to 3 years of age, so it doesn't truly apply to Annie, this 14-month-old kid. We can use a bronchiolitis scoring tool, but even if it's not validated there, at least it provides us some indication if the kid's responded or not. So here's the tool. So suprasternal indrawing or tracheal tug is the other informal name for it. Scalene retractions, that's a tricky one. It's actually something you palpate, you don't actually feel. You don't actually see, I mean. So if you actually just kind of grab hold of your neck and bite down hard and feel those muscles that tighten up, those are the scalenes. So when a kid is tight and trying to breathe, they're using every muscle they can to pull their lungs up and open. So you'll see those scalenes retracting or feel them retracting. And that's what's happening is they're trying to just open their lungs a little bit more. And I had something else to say about scalene retractions, but I've forgotten it. Anyway, and wheezing, of course, we'd expect that in lots of cases. One trap here, if you can see, so absent wheeze, and this is really a critical one. I've seen this missed a lot of times. Yeah, kid's not wheezing. But if you go down here, sometimes they're moving so little air, that airway is so tight, there's not enough air moving that you can even hear the wheezing. That kid should look quite sick. So if a kid is struggling really hard to breathe and minimal airflow, you may be confused that it's not asthma because there's no wheeze, but it might be that this kid's just not moving enough air to make a wheeze. We start treatment on those kids, and all of a sudden, 20 minutes later, after that first round of salbutamol, they're moving a lot more air. They're now wheezing. It's not that they've gotten worse, they're getting better. And the clue should be that now they've got more airflow. So the breath sounds were fairly quiet before, no wheeze. Now the breath sounds are better. The effort is hopefully better, and the wheezing is present. It means they're getting better, not worse. And then our oxygen saturations. So, and you'll see on the TREK asthma guidelines, the bottom line recommendation and so forth, that there is some variation regionally in both PRAM score severity and altitude affects this. So if anybody's working in Alberta, actually Calgary has a slightly different PRAM SAT score. So good thing to consider at altitude. Okay, so here's Annie's PRAM. So she's got some suprasternal retractions, marine drawing, the scalene, sensitive mouse. I should keep my hands off it. Expiratory wheezes, but she seems to have actually decent breath sounds, lots of crackles and stuff, but it's there's air moving quite well. And she's 90%, so she's a little bit hypoxic. So that gives her a PRAM of 7. If you want, and this is linked on the TREK material as well. If anybody has MD Calc, you can do the PRAM on there as well. Okay, so we got a PRAM of 7, but I don't know. Annie's a little kid, bronchiolitis. What should we try? Well, we know that our treatments for bronchiolitis are pretty lousy, but if she has asthma, it kind of sucks for her because it's more chronic. But hey, let's try salbutamol because at least if she has asthma, we have something we can give her. So let's give her some puffs. We really don't use the nebulizers very much anymore. We go straight to the aero chamber with the blue puffer. And the reason I put the 5 to 10 puffs here is, again, different regions, different organizations that create guidelines and stuff give you different numbers. 5 to 10 puffs. You give her some puffs. Usually for a kid her age, and the newer guidelines would be about 5 puffs. And you wait. Give her a few minutes. And, okay. She's starting to drink now. She's a little happier. Her SATs have come up nicely. Still a little wheezy. Still a little work of breathing. So she's not back to normal. Now, I struggle building this slide a little bit because I'm trying not to confuse people. So she has improved. She's not perfect. Her PRAM, though, it's now down to 3. So what do we do with her? What I'm trying to get at here is we really only partially treated her. We gave that first round of puffs for, I use it like as a diagnostic test. Let's see if this is asthma. If she responds nicely, then okay, it's probably asthma. But we need more treatment. She's not better yet. Her PRAM was pretty high. That's in the moderately severe asthma. So this kid actually needs the full asthma care plan, which hopefully, if most of you have that in your site, whether you have it from Children's Hospital or your own region or the TREK guidelines. And Children's Hospital we're redoing our asthma guidelines, and they're going to align now with TREK. There's always this couple dosing things that were different, but we're aligning that with TREK. So either way, you're going to get the same treatment pretty much anywhere in the world where you look up asthma guidelines. So although she's 3 now, I would still be classifying her as a moderately asthmatic because her PRAM was higher. So we would continue. So we would finish the asthma care plan, and this is maybe a little hard to read. So here she was a 4. So we would actually give her the salbutamol 3 doses over 20 minutes, or spaced by 20 minutes. And ipratropium, that's when we're hedging on a little bit, but when you're sicker, we use ipratropium or Atrovent. It may make you a little bit better, decrease your admission rate. Not huge. Big one though is making sure we get that oral steroid into her. So even though her PRAM, Annie's PRAM has gone down to a 3, she kind of meets the mild criteria. We started out at moderate and we only partially treated her. So she needs the full treatment. So I hope I didn't confuse people like that. I was just trying to make sure that you know that you trial it. It worked. Let's continue. If we trialed it and absolutely nothing happened, particularly if she was much younger, if she's a 3 or 4 month old, we don't typically try it there. But then we wouldn't expect to see a response and we'd continue treating as bronchiolitis. All right, so she gets the full asthma care protocol. I just enlarged it a little bit. It's a lot of stuff here. We're not going to go through that in much more detail for now. All right, so she got that first round of puffs, and a key point that I should have mentioned earlier, we gave her that first round and we waited 20 minutes. Don't wait, and when we're busy, right, you might get tied up and you don't get back to her for an hour or more. We want to do this fairly aggressively and fairly quickly. So get back to assess her in 15, 20 minutes, and then right away is proceed into the rest of the care plan. So she would get 2 more rounds of salbutamol for a total of 3 with the ipratropium too, and the oral steroid. And the sooner you get the oral steroid in, the better, because it takes several hours to work. So if we delay that for an hour, that's 1 more hour before we're going to start to see a benefit from that. But now her vitals are normal. She's got a little bit of a cough, still going to have that snotty nose, hardly any wheeze or no wheeze at all. And the most important stuff that we still have to do is what we have there on the list. So whenever we see somebody with potential asthma, it's important they know what we're dealing with. So what is asthma? A basic explanation. Give them your management plan, not just what you were doing today, but what we're going to do when you go home. Know why and when to return. That's a big one. And my big worry with that specifically is when families are not as used to the medical system. So if there's language barriers, relatively new immigrants, so forth, that's where I really think it's most important that people learn how to manage their asthma and when to come back. So trying to find language appropriate materials, translator, not ideal, but even if you can get a relative to translate something like that, that's a big red flag for me. And then have a follow-up plan and when to see their primary provider. So there are these resources on the Trek page. Right from the start of Trek, there's really good data to show that when you hand someone a pamphlet, or at 3 in the morning when they're exhausted and their kid is crying in their arms and you're trying to teach them on something, people aren't going to remember it. And handouts have been shown to be not particularly useful. I still don't think I've read my kid's braces handout that was given to me like 6 years ago and the braces are gone. So I think I'm the norm maybe for that. So we know that stories work better than just data points on a sheet. So there's an asthma infographic on the Trek page, a video about managing asthma. So look at those and encourage families to look at those. Okay. Actually, Matea, I noticed there's been a few questions. Should we take a pause and address some of those, or should we keep going? I don't know. We'll keep going for the moment, maybe. You can cut in and let me know. There's some gem questions that might be relevant to what we've talked about in the last little bit. Okay, so you've let Annie go home, and then Bob comes in. I would love to meet a 7-year-old named Bob, but it's kind of a good name. And maybe this is hitting a little too close to home. I don't know if anybody's from Northern Health Region or how many people are on, but Bob comes into the PAW ED today. It's been smoky out. There's fires in the area. He's been sick for about 24 hours. He's really coughing. He's got, that plugged up nose. He's not really got many secretions, but he's got that nasal voice because he's congested. In the last few hours, he's had increased work of breathing. He's not really ever had asthma. He got, about 2 years ago, they gave him a puffer when he had a cold, and they weren't sure if it worked or not. But they both pulled out that puffer, and they tried it 3 times today, and he's had no real improvement. He's sitting up. He's scared, he's pale, he's got trach tug, he's responding in single words. Potentially, hopefully he doesn't get to this point, but he's drowsy, he's not responding very well. His respiratory rate's 46, quite high for a 7-year-old. His tachycardic pressure's okay. He's not horribly hypoxic, and it's unlikely in asthma to be severely hypoxic. I had a kid who came in a few years ago who looked like asthma, but the presenting saturation was in the 60s. It was staying there. It wasn't just one of those dips or a misread on the sats. I started treating his asthma, but fairly quickly my brain went, wait a minute. You should not be conscious and breathing and alive if your sats are 63% with asthma. This kid's effort wasn't comparable to that sat number. So when you have a sat like that, consider other diagnoses. You'll see them certainly, in the 80s, even low 80s, but not much more than that until they're in, imminent respiratory failure. Low-grade fever, just to make it more confusing. So yeah, you again increased work of breathing, the same stuff that we kind of saw with Annie, but quite pronounced. Very faint wheeze, or again absent wheeze, like I was saying before. Heart sounds normal. So yeah, we're still talking about asthma. We don't know yet, but could potentially be status asthmaticus. How bad is it? So if we put the PRAM on him, and we can do the math here, but I'll just quickly show it. So he's up there, right? So 2, 2, 2, 2, so 8. Yep, 8 and then 3 here. So his PRAM is 11. So that's up there. If you look on actually I have it here. Yeah, it's too hard to look at, but basically he's in the severe asthma zone. So we need to treat this guy urgently and aggressively. Here's the brand new, as of February, severe asthma algorithm. Talks about the key stuff. The whole point behind these guidelines. Yeah, you can go and read the Canadian Thoracic Society 40-page guideline on this kind of stuff. But right now, Bob's sitting in front of you. You have minutes to start treating him. So this is meant to be as clean and crisp as possible. So recognition, okay? How to treat him initially. This is the stuff we're doing, within 5 minutes of him landing in the ED. A small point there, I know this is tiny. I should go to the next slide. I'll go to that. But the small point to make sure of is things like make sure he's not hypoglycemic, right? They have been putting a lot of energy into breathing right now, not feeding very well or drinking very well. So just make sure you think of that. And think of this one too, right? Anaphylaxis. He's not an atopic kid or not known allergic. And there's a good suggestion that it's asthma, but keep anaphylaxis in the back of your mind for these severe kids too. And then once you've done the treatment, this is that protocol broken apart a little bit. Here's where to go post that first 3 rounds of salbutamol, post that oral steroid. And then there's red flags on that protocol too. So if you look at it, these are the things you really want to be careful about. Intubation is a high risk thing. Here's the full asthma order set. So I don't know if your region has to approve this kind of stuff or you can simply download it from Trek, but it's all very standard conventional treatment for severe asthma. Not going to go through it, except one huge point. I said a while ago that we don't use nebulizers anymore. One big problem with the meter dose inhalers is you have to be able to draw in air. You have to suck it in. If you're that sick that you can't suck it in, we do switch to nebulizers. So we put the nebulization on and hopefully they're moving enough air to get some of it down. The deposition isn't as good in a perfectly healthy, perfectly normal kid. The particles are bigger. A lot of it lands in your mouth or even on your face if you have a face mask, not the mouthpiece. So we ideally would like to use a meter dose inhaler, but it's not an option in these kids who are really sick and tight. So we back away from that and move to the nebulization. And this kid, I'd probably or very quickly go to continuous nebulization. So he's just going to need this going in as long as he's there. I've seen a lot of kids who are sent down, and there's a big reluctance to keep going with the salbutamol. They're like, his heart rate's 210. He's vomited. He's really jittery. I'm worried I'm causing an arrhythmia, or maybe he is an arrhythmia. Young, healthy hearts, no significant comorbidities. We don't worry about that. What's our option? If we can't give him salbutamol because his heart rate's too fast, what are we going to do? He needs that salbutamol, period. So yeah, we're going to give some continuous salbutamol. He might be too sick to handle an oral steroid, so we would give it parenterally. You can do an IM injection, but you're probably going to want an IV in this guy anyway. And then these are the kids that would for sure get the ipratropium, even if it's not a massive benefit, that little bit of extra. So we've done all that. Where are we going to go next? We've got this running. And you might be able to see it on this protocol, but you can go to the website and see all of this. Okay, a summary of what's on that sheet. I'll get to that. Minimize interruptions. I talked about that with Annie, right? We want to get back to her and assess her quickly. And same with this guy. Let's say we did decide to do the Q20 nebulization or metered-dose inhaler. Once that Q20 is finished, you've got 3 rounds in, get back there. Don't go back there an hour later. Get back into that room at the 40 to 60 minute mark to see if this kid's doing okay or not, needs more. Oh. All right. I've talked about this already. So the MDI is more efficient and fewer side effects, right? Just talking a minute ago about the tachycardia, the nausea. More kids will vomit and have nausea and get really jittery when they're on nebulization because they're swallowing a lot more of it. It's going through the GI tract, not the respiratory system. And they get out of the ED quicker. And although the evidence doesn't say this, we do believe that it does seem that you have fewer admissions, but the evidence is kind of on the cusp of significance there. And a big one is that there's no aerosol generating procedures. So with this, but this kid, Bob, can't handle it. Bob needs nebulization because he doesn't have enough airflow to use the MDI. And yes, you can use it on a cat, apparently. Probably not the same one you use on your kid, especially for kids cat allergic. Okay, the steroids, get them in early so they work quickly. Moderate to severe exacerbations. And here I'm going off script a little bit. The evidence doesn't support using it in the very mild cases, the kids who come in with a PRAM of 2 and a little tiny bit of wheeze. So it's not usually indicated. I still give it. And this is purely non-scientific, anecdote-based medicine, but I've seen enough kids who are back the next day. They were PRAM 2 yesterday, and they got 8 puffs and they went home. And now they're PRAM 6 or 7. And we may have disrupted that if we had given them steroids the day before. My argument is that, yeah, we don't have evidence to support that, but we don't have good evidence overall. And a single extra dose of dexamethasone, I don't think the risk is so great. So, yeah. And what about this one? This point at the bottom here. We see this all the time. Either the kid's on a steroid and actually taking it, which is pretty uncommon, or the steroid's been sitting in the shelf for the last 3 months, and the doctor has told them, okay, when you start to get symptoms, go and take that puffer. And what do we think? Is that helpful? Bottom line, not. So it's too little, too late. We need that inhaled steroid in us for about a week before it really starts doing anything. So taking it the day you get your cold isn't going to help you at all. And there's actually 2 studies, both published in, I think, 2001 in the New England Journal. One was quadrupling and one was quintupling your steroid dose, and it was not beneficial. So, and that's giving pretty high doses by that point. Okay, we talked about this. We do have to watch a little about those kids with congenital heart disease or known arrhythmia. I'm not sure if Dr. Grip is on the call, but I actually forgot to tell her about this kid with asthma that I signed over to her who also had a history of SVT. And about 6 seconds after I left the ED, the kid went into SVT. So sorry about that. So yeah, that's a lesson in good signovers. But again, it's like I said about the tachycardia. We don't really have much choice. If this is truly asthma, and you have to think about other things when you have kids with heart disease, we have to be, we pretty much have to use it. So, but give families a warning ahead of time. It looks a lot worse if you go in the room 20 minutes later and say, oh, she barfed all over the place, this stupid medicine. So I tell them, yeah, they can get nauseated and sometimes throw up, less so with the MDIs. And they're always jittery and they're bouncing around the room, which is great when you give it to them at 1 a.m. and the kid's up for the rest of the night. So, and magnesium. So we've been using magnesium for years and years and years, and there's actually, it's still recommended, but there's some question about whether it's the magnesium that fixes you. So if you do have a kid who's not that much better post-care plan or severely ill than even earlier, we do give magnesium. It might be that the evidence doesn't show that it works because we're waiting too long. Sometimes we're sitting on them for 2 or 3 hours. It's like, oh, this kid might have to go to ICU. Let's give him magnesium to keep him out of ICU. So that might be why it's not working. Or it may actually be getting credit for working when really what it is, when you start the magnesium, you continue with your salbutamol. Keep going Q20 or keep going with your continuous salbutamol. We don't know if it helps or not. Still recommended. And we would continue until we get better data. It's not that harmful. We give it slow because it can cause hypotension and never actually been reported, but theoretically possible to cause cardiac arrest. So give it slow. They can get a warm, flushed feeling that can make them feel quite gross. So slow it down a little bit, but give it early. And if they're severely ill, really 60 minutes or even sooner post your first dose of salbutamol. And it does not mean admission is required. There's a survey from a number of years ago, and actually I just saw a recent one from Europe as well, where we were delaying giving it until we were trying to keep them out of intensive care. And then everybody's conception of the survey was, well, if I've given magnesium, I have to admit them. No, if they turn around and they meet discharge criteria, they can go. So, okay, so we're doing this all with Bob. Bob is still struggling. You're worried that he's starting to fail. So we hopefully have already contacted the transport team. If a kid came in pretty extreme asthma, I would probably be calling the transport team after my first 1 or 2 doses of salbutamol. And if I'm starting continuous salbutamol right off the hop, I'm calling the transport team pretty much at that point if he's that sick. Good to know what you have. Again, I don't know who all's on the meeting here today and stuff. Know what your facility has. Do you have Optiflow? Do you have the capacity to do CPAP? Even if you know how to use a Jackson Reese bag and do your own informal CPAP. Know who's around. Do you have a GP anesthetist in town, or get what you have, or know what you have and know who you can call. And as that warning sign mentioned on the asthma algorithm, intubation is high risk, so we would try and avoid it. We would support them as much as we can without intubation. We would look at things like blood gases. Again, if you're at a nursing station or tiny health center, you might not have access to that, although iStats are more readily available now. If you are ventilating these kids, intubated or not, very slow ventilation. So we gently push air in and then give them a long expiratory time. And a couple of the STARS paramedics were telling me about a case they had where they would actually give this woman who was intubated 4 or 5 breaths, she's an adult, and then they would completely stop and they'd lay their hands on either side of her chest and press out the air. Never got into that. Don't want to do that. But that they were an extremist. But you got to be ready for managing the barotraumas. Then all of a sudden you feel like there's Rice Krispies under the skin along the neck here. They're deteriorating fairly acutely. You could have a pneumothorax or pneumomediastinum, and be prepared to manage that. And this is something I didn't even put in here, but kids will end up on ECMO, so basically cardiac bypass, if we can't get them treated. Other thing that we have to always think about, and it's mentioned in the guideline, is anaphylaxis. But think about other stuff. Maybe the reason he's not responding is because I'm not treating the right condition. What if there's a foreign body in there? So toddlers especially, or little kids run around and they get something in their airway. I had a kid who had an almond in his airway and he was wheezing bilaterally and it really looked like asthma. Pneumonitis. So this kid maybe had an aspiration event, especially in disabled kids, maybe they're tube fed or whatever else. They reflux up and let that go into their lungs. You might still be using salbutamol to help with this. A drowning, if got significant lung inflammation from that, and all this other stuff too. I wouldn't label it psychogenic if it's extreme, but there's been times when we've questioned it. You can tell sometimes people are closing their glottis voluntarily. They sound like they have stridor, but don't shut the door on them. I've learned this several times, and you'd think it would stick with me, but hypochondriacs get sick too, is one of my lines. And just because the kid's been there 17 times with the same presentation and they were discharged with, it's all in your head, they can still get sick. There's nothing precluding that kid from having anaphylaxis or bad asthma exacerbation. So just keep it in mind. So discharge criteria. So Bob is not going home. Bob is going by a transport team to PICU. But when can you send these other kids home, like Annie and other kids? So if they're still pramming, 3 or less, 1 or 2 hours after the last bronchodilator, think about their history though. If they nearly died of asthma 6 months ago, you might keep this kid a lot longer. No significant work of breathing, maybe a mild wheeze still. We don't need to be perfectly normoxic with it as long as they're generally improving. And thinking about all those other things. So if you're in Lac Rocher, I'm not going to let you go back to Lac Rocher when I'm sending you out to the ED if you had a decent asthma attack. I want you to stay in town for a day or two. If you're around smoke, both atmospheric smoke like we're seeing right now, or there's lots of smokers in the home, and it is true, right? When that scent of smoke is on people's clothing and stuff, that's enough to trigger some asthma. Potential ability to manage. So if the parents are single parent, 3 or 4 kids in the home, they're all little, they're all sick, nobody's getting any sleep. They don't have a vehicle to get back to the ED, or they live, again, a fair ways away, even if by road. You might want to keep them around a little bit longer. And then prior severe exacerbations, like I said, and the comorbidities. So if this kid has asthma, but also some risk of aspiration or some kind of heart disease, something like that, you might want to keep them around. We are now prescribing anybody who has a significant exacerbation the inhaled corticosteroids. So this is the reliever. This is the salbutamol. That's the rescuer, the reliever when you're in trouble. But here, all children should go home on a controller. So that's the inhaled corticosteroid that we would give them at least until they see their primary provider, or 2 or even 3 months, all because of that newer data that says that these kids are getting permanent airway remodeling when they're pretty young. Hard to get people to stick to it. I don't have the stats, but I would say the majority of people give it for a couple of weeks and then it's back on the shelf. I get it. People don't want their kid to be on a medication for a long time, but very crude math. I didn't put a lot of science into this, but if you get 6 doses of dexamethasone, which when you come to the ED, you'd either get 1 or 2 doses, depending on how sick you are. So if you get 6 doses of dexamethasone in a year, that's approximately, depends on dose of inhaled steroid, but that's approximately a year of inhaled steroid. So if you're coming back 3 or more times to the ED, you're getting way too much steroid effectively. So maybe we can keep you out of the ED at least 1 or 2 of those times by staying on your inhaled steroid. Yes, there is a little bit of a growth consequence, but poorly controlled asthma may also have growth consequences, and again, that permanent lung remodeling. So there's where teaching and good information is important. And then they should know how to manage it, how to manage the exacerbations, how to step it up when they get worse, and so forth. All right. We'll try to finish up really quickly here. I've got a few minutes, then we'll have our chat. Just a few extra points. I haven't talked about chest x-rays. Do you want to do one? Don't know. Should I not? Generally, no. If you have a kid who's not that bad, there's not really any benefit to doing a chest x-ray, and there is some drawbacks. It's really when we're looking for a different diagnosis or a complication, like they've got a pneumothorax or something like that. The problem is you see this little bit of fluff. Oh, look at that. There's a little bit of junk there. I think that's a pneumonia. You'll see that in lots of kids, regardless. You'll see it in kids with upper respiratory infections or minor viral symptoms. Pneumonia does not equal bacteria. So even if it is a pneumonia, in this case, the kid otherwise looks entirely viral, healthy, vaccinated, so forth, it's probably viral. So we can really back off on our antibiotics for this. The other problem, if the kid's crackly and has a wet chest, but you don't maybe appreciate the wheeze, or they are febrile, is we kind of just go down the track of it being infectious. And we stick to infection. We x-ray you, maybe do a swab, we start you on an antibiotic, and we didn't realize it was asthma. And that actually, I have a lot of experience with seeing that, where kids have come in and 24 hours ago, they were seen and were given, a Moxil or a Zithro, and then they come to the ED with worsening of their asthma exacerbation. So most of the time, a good rule of thumb is that pneumonia rarely wheezes. All right, and then anybody a Scooby-Doo fan? So if you can name all the characters, but so yeah, the problem with teenagers, and they're, nobody wants to be tied down by an illness. Nobody wants to be labeled. Nobody wants to carry this dorky stuff around. And I want to eat and drink and do what I want. Don't care about being exposed to smoke and so forth. Putting the salbutamol in your mouth, even a well-trained person, or the inhaler straight into your mouth, doesn't work as well. And often they're coming in like 3 weeks later, they've used up the whole inhaler. And they've been in the ED now for 4 or 5 times in the last 12 months. So a couple of things we can do. One is, yeah, they hate these things. They're uncool, they're a hassle to carry, the aero chamber, I mean. Maybe they would like a turbihaler. So it's the dry powder inhaler. You suck the medicine in. Only problem, as it is even with this, is if you're having a severe exacerbation, you can't suck that medicine in. And you got to be a little older to know how to use it. But actual deposition and effectiveness is better. And you can get relievers and controllers or inhaled steroids via turbihaler. So that might be useful. And then the Global Initiative for Asthma, or GINA as it's called, they've suggested in select kids who don't want to take their inhaled steroid, you basically send them just with a combi inhaler, which I know some drug plans don't cover. Specifically, I know FNIB doesn't cover, so First Nations Inuit Health Branch, or it doesn't cover a combi inhaler unless you've failed a single inhaler. But basically what you're doing is you're giving these kids their inhaled steroid kind of against their will. If they want to take their reliever, they're getting a bit of controller anyway. So we'd hopefully be able to prevent them from having as many exacerbations because they're self-treating with the steroid.